Penny's the Deputy Director of Rehabilitation and Therapies and the Professional Lead for Physiotherapy at the Royal Brompton Hospital in London, where she combines a strategic operational role managing therapy services with a continued clinical interest in cystic fibrosis. Penny graduated from King's College in London in 1994 and has been the lead physiotherapist for CF in the Trust for the last 15 years. Her specialist interests in CF and research focus around complex disease, non-invasive ventilation, end-of-life care, airway clearance and inhalation therapy, and she's lectured extensively both nationally and internationally. Penny's the chair of the National Association of Chartered Physiotherapists in Cystic Fibrosis, the ACPCF. Try and say that 10 times fast when you've been drinking. From 2009 to 2012, and she co-edited and led the National Standards of Care and Good Clinical Practice for the Physiotherapy Management of People with Cystic Fibrosis, published in 2011. She's the course facilitator for Managing the Care of Children and Adults with Cystic Fibrosis course, which is accredited by the European Cystic Fibrosis Society and run twice yearly in London. And she promotes education in CF through working with the IPG CF, which I'm sure you will agree with, a very impressive set of credentials like that. We're going to get a really great talk today. So, Penny.
Thank you, Kate, for that introduction. I hate hearing about myself, so please feel free to have switched off for that bit. So I'm going to talk to you about physiotherapy and focus on the other aspects than just airway clearance, because although... Is this working? If you press it harder, does it work? This happened to me yesterday in the physio course as well. Oh, there you go. Okay, about 6 times for each slide. So physiotherapy has always been traditionally thought of as just airway clearance for CF, really. And certainly when I started as a respiratory physio and then became a CF physio, we just seemed to really focus on the lungs. But I've kind of grown up learning about CF as I've worked in it, and it's certainly very much more than just the lungs. It's quite tricky standing here today in front of you knowing that physiotherapy is absolutely hated by people and families with CF. So it's kind of no mean feat to have to convince you how wonderful physio is, because obviously I live and breathe it. Not quite that sad. But knowing that it does encompass lots of different things, it's going to be a little bit awkward. So generally, the accepted terms of the definition of CF for physiotherapy is that it is a combination of a variety of things. So we acknowledge today that it's a combination of inhalation therapy, airway clearance techniques, physical education, exercise, and then ongoing education about the disease and its treatment. But that would also include things like musculoskeletal issues, posture, urinary incontinence, a lot of other aspects as well. And the International Physiotherapy Group for CF have got this definition. I'm slightly worried I might fall off the stage here. It's primarily preventative, what we do, although looking at the evidence to show how it's preventative, that's quite tricky. And it should be incorporated into each patient's daily routine. So we know that it is a mainstay of your regular treatments, along with good nutrition and kind of taking all your medications and stuff as well. But we appreciate that we're a massive burden of treatment as well. And obviously when we were just considered to be airway clearance, that was kind of bad enough. Now that we add in everything else, so exercise, posture, continence, inhalation therapy, the list seems to grow each year or each month that physio comes up with something else that you guys have to do. So fortunately, I don't consider myself to be a respiratory physiotherapist anymore. I consider myself to be a specialist CF physiotherapist, because if I call myself a respiratory physiotherapist, I think you miss out on lots of these other aspects of CF. It's not working. Okay. And these are just as important as all the other bits. So each component part you need to have a focus on, and they may not play a part in every single aspect of your day-to-day life, but potentially at some point in your life, as long as you're female, being pregnancy management, obviously that wouldn't apply to men, although your partner could obviously be having to interplay and manage those aspects of physiotherapy, really. So, although this is about more than airway clearance, we are going to start with airway clearance. So airway clearance has been around for absolutely donkey's years. So it started for CF around in the early 1950s and was quite archaic what people did, hanging over the edge of beds and things and doing a lot of postural drainage and not really a huge amount of thought into the physiology of what people were doing. But, you know, as knowledge has grown, then techniques and the diversity of techniques that we can use has grown as well. So within the spectrum of therapies for cystic fibrosis, it really does go back a long, long way. And I think within that, you could kind of say that things like inhaled antibiotics and DNAs are certainly physiotherapy related as well with the management of them, or lung transplant with rehabilitation pre and post transplant as well is often, you know, incredibly important for the success of that. So why do we have to do airway clearance? Well, obviously from the nature of the defect in CF, in that where you've got your cilia in your airways that should be moving nice and uniformly and sweeping secretions up through your mucociliary clearance escalator, in CF, because the airway surface liquid is reduced, those cilia, those hairs don't beat as smoothly and they're all a bit stuck with heavy mucus sitting on top. So it's a bit like a row of ants trying to move a house brick or something. And you get dehydration of those airways and dehydration of those secretions. So trying to move them then becomes like a vicious circle where you have the prospect of bacteria binding, which then facilitates the growth of more bacterial. You then get inflammatory products and inflammatory mediators and greater inflammation within the airways. And that affects neutrophils in the circulation. You get the bronchial wall damage, and you get your defective mucociliary clearance system. And this is a perpetual cycle. So physiotherapy is aiming to break parts of that cycle and augment clearance to enhance it. So the basic principles of airway clearance are that you would improve those natural mucociliary clearance systems that everybody has. The aim being to reduce your mucus plugging and use physiology. So any airway clearance technique, to be successful, it needs to have a change in airflow or a change in ventilation. If you're sat there as you are now doing relaxed tidal breathing, you're not actually doing, hopefully no one's doing any airway clearance right now, because you're not changing your airflow and your volume and your ventilation within your lungs. Removing secretions containing bacteria helps to reduce local inflammatory responses. But obviously it's a perpetual thing that needs to be done regularly. You can't do it once a week and hope that will cover you for the whole week. So we know that in CF you have some obstructive airways. So the picture with the purple airways on it. If you have a slightly obstructive airway, air will always take the path of least resistance. So it will go into the airway that is nicely open already. So not particularly convenient when you're trying to open up your airways, get air behind secretions. So hence a lot of our airway clearance techniques have very slow inspirations with inspiratory pauses to try and use collateral channels between your airways to try and get air behind your secretions and making it easier to move up. And then looking at enhancing expiratory airflow, because obviously to move things out, it needs to be greater than the airflow going in. So short term, really, the objectives and the aims of doing airway clearance regularly are to reduce your airway obstruction and reduce the resistance within the airways, hence making clearance better and more efficient. And obviously then to increase your ventilation, increase your airflow, so opening up those small airways. Long term is a bit more tricky. The aim is to delay disease progression, but obviously CF has such a great diversity that even those people who do airway clearance religiously every single day, you can still have disease progression with it. So it doesn't kind of cure all, really. But also there to maintain and optimise your respiratory function. So the factors that influence certainly physios working with their patients to choice of airway clearance technique, it shouldn't just be the physio dictating to the patient what clearance technique they should do. If it's something that doesn't fit in with that individual's lifestyle, they're absolutely not going to do it. So yes, we need to take into consideration the things like sputum volume, how much you produce, the degree of lung tissue damage or evaluation of a CT scanner, chest x-ray for those kind of things, and your lung function scores. Looking at the amount of airway obstruction you have, airway hyperreactivity, because some of the techniques that we can use may induce hyperreactivity, so we don't want to make you worse, and hence you'll hate us even more and not do it even more. If you've got any instability in your airways, then you may need some kind of positive pressure to splint them open, things like that. But then looking musculoskeletally at your chest wall, what is your thoracic cavity like? Looking at the mobility of your chest wall, because, you know, with complex disease and with aging, your chest mobility can reduce and your compliance can reduce. So looking at the biomechanics of your spine and things as well. Looking at the motivation that you've got. So I totally appreciate the majority of our techniques are incredibly boring. You know, yes, they're developed from the 1950s, and even those in the 80s, 90s, and the last kind of 10, 20 years or so, no one's come up with the most really fun technique for physio. They may be a millionaire if they do, if they get everyone to do it. But looking at the time it takes, so everybody takes a different amount of time to do their airway clearance. It depends on them and their individual disease process. Looking at the surroundings of how they do it. Are you going to be able to do it at work, at school? Is it just something to be able to do at home? Looking at that individual person's choice as well, so that you have a marry-up, a complete, you know, choice together of what is best for the person. And potentially for some people, because of the nature of their disease, there may well be some risk factors and precautions and some contraindications that we need to take into account. So this is just a summary of a range of techniques, and it's not necessarily all ones that we use. So self-administered ones, which I really truly believe that everybody should be taught at least one technique that doesn't require any equipment, because it's very convenient to break a piece of equipment, forget it, lose it, not clean it, so it's really dirty and stuff. But if you have one technique that you can use that doesn't require any equipment, that can, if you are away and you've forgotten your pep or flutter or something, you need to do something, you can always have something to fall back on. Now, certainly the first two of those, in the UK, we would recommend that everybody be taught one of those two techniques. But obviously I'm talking about people from kind of 4 or 5 years onwards, because you can't teach a child less than the age of 4 or 5 active cyclo-breathing techniques or autogenic drainage, because they just won't understand what you're saying. You can do things like blowing games, things like that instead. The majority, all except autogenic drainage, include the forced expiration technique, and I don't think we should really consider it as a technique on its own independently, although using the forced expiration technique is now commonplace throughout just about every airway clearance technique. I say that it's not really in autogenic drainage because it's not a true FET that AD does. It's more of an exaggerated sigh and controlled expiration rather than a forced expiration. Certainly some people who are very well, who have very good levels of lung function and don't have really huge sputum volumes either, may well survive for their daily airway clearance by doing exercise and forced expiration. But it really depends on your individual level. MOPEP is something that I don't recommend at all, but it is out there and people talk about it, and I appreciate there are chat forums and things, and it's a mouth positive expiratory pressure. If you haven't got a device, and you usually do have, you can kind of do some pep into your fist, which, you know, as a last resort is okay. But I don't think we can consider it as a true airway clearance technique. Variety of devices, so positive expiratory pressure is very popular, and there are a range of devices for that. Oscillating positive expiratory pressure, so we would commonly use the a cappella and the flutter. The cornet was used in Europe for a bit. We don't use it in the UK at all now because you can't really clean it, and the rubber hose and it sticks together, so it's actually quite a high risk of a large back pressure when you blow into it. And then we have a whole host of mechanical adjuncts. Mainly of these are when people come into hospital during exacerbations, but we can give extra treatments on top of what they would normally do to assist airway clearance and make it easier. So intrapulmonary percussive ventilation, high-frequency chest wall oscillation is commonly known as the VEST and is used a lot in America. And they should really get to grips with the rest of the airway clearance techniques. Non-invasive ventilation, that's a polite way of saying it. Non-invasive ventilation, obviously used for respiratory failure, but we use it a lot quite early on with patients and to augment their airway clearance as well. And it also helps reduce the stigma of non-invasive ventilation. and a fantastic device from the 1950s called the BIRD, which is intermittent positive pressure breathing, which really helps you to take a deep breath and gets air behind your secretions. And then something called a cough assist, which isn't used hugely. We kind of have one that sits in the cupboard, gathers dust, comes out a couple of times a year or so. And then ultrasonic humidification, rather than an airway clearance technique, but actually augmenting your hydration. So I've put in gravity-assisted positioning because it was something that was a mainstay of treatment for many, many people. And I think for a lot of people today, they may use it in a modified form, so not a head-down tip form, because we know from various lots of research that obviously with having reflux and the negative effects of being head-down tipped, although it was a mainstay of treatment for a good kind of 30, 40 years in CF. But individual efficacy for people has shown that you can clear just as much if you have gravity neutral in modified positions than actually head down, and then you don't have reflux and headaches and feeling sick and things as well. So far, far, far less commonly used. We have about 600 adults at the Brompton in London, and we probably have 2 patients out of those 600 adults who still use head-down tip postural drainage. And every time they come in, we will go through and try and evaluate if we can get them to do something different, but they are very, very resistant to change. So thinking about airway clearance in infants, obviously infants aren't just small adults. There are physiological differences for infants, and we need to adapt and tailor our treatment regimens to that as well. Particularly looking at careful monitoring so that parents and families know what to assess for, because our children born today with CF are much healthier and don't have as many kind of hospital admissions or infections as kind of 10, 20 years ago even. So looking at the techniques that people do and still carrying on with knowing about reflux and not using head-down tip positions, but doing things like bouncing on a ball with assisted autogenic drainage, some therapeutic exercise, baby pep, lots of positioning and active play, because like I said before, you can't get a toddler to follow you with instructions and do what you want. You can't often get a teenager to do it either, but we have to treat them as adults. And then educating the parents and the families so they can also make their choice as to what airway clearance fits in best for them, and making sure that they know a good assessment tool, so knowing the signs and symptoms of infections or if things are going slightly awry. So thinking about the evidence, there are lots of short-term evidence trials for airway clearance, so kind of 2-day designs in a hospital, crossover of 2 different techniques, things like that. And there's a handful of long-term trials. So the top one done by Jennifer Pryor, which was a physio that I worked with at the Brompton. This was her PhD study looking at, is there one best single airway clearance technique? Because people often ask us, is there one technique that is known to be better than all the others? Well, the simple answer is no, there isn't. They're all pretty much equivalent. So Jennifer did a 1-year study looking at 5 different airway clearance techniques: the active cycle of breathing techniques, autogenic drainage, positive expiratory pressure, the flutter, and the cornet. None of these included postural drainage. We completely eliminated that, and they were all done in sitting. And actually, lo and behold, it showed that there was no significant difference in any technique. And then just recently, a really good study from Maggie McElwain in Canada last year, a multi-centre trial looking at the vest, because obviously in America it's the most commonly used technique, against PEP, the most common technique used in Canada. So 12 centres took part in this trial, and it was actually a really good outcome for people who were using PEP, because those who were using the vest actually had twice as many exacerbations and twice as great a need for using IV or oral antibiotics as well. So really not good for long-term use of the vest. Hence, certainly in the UK, in Australia and New Zealand, we pretty much don't use the vest. We use it a little bit in the UK, but not very much at all. I think it's an adjunct that's there for some people, but it certainly isn't right for everybody. I'm an instructor of airway clearance for the IPG, and we teach very much purist techniques. So trying to educate physios working in CF how to do the correct form of airway clearance techniques. But then there are always those people who challenge you a bit when you're confronted with a patient who doesn't quite fit that perfect technique. So I very much like doing combinations of techniques and kind of stripping back the the problems of the patient and what we're trying to achieve with airway clearance, and then combining some principles from a couple of techniques and putting them together to make that person's own individual technique. Now, that's extremely difficult to evaluate in any study, and those people who invented those techniques would probably shoot me down. Most of them are retired now, to be honest, so I think I'll be all right. But because everybody isn't a textbook classic example of somebody with CF, I think we have to be adaptive and change things to suit the individual, because you'll vary from day to day as well, so we need to give you tips and understanding of what is best for you to do. So we do have a whole host of recommendations, certainly from the UK and Australia. There's some really good guidelines. This is a summary, just briefly on the left, of some of the UK ones. On the whole, there isn't a huge amount of strong, highly graded evidence for physio, but like I say, that really comes from long-term randomised controlled trials, and it's just incredibly difficult to do those. But basically, we know that people should be taught one of the key core airway clearance techniques. And a first-line treatment, like I say, should be one that doesn't include a piece of equipment, really. But definitely patient preference should be taken into account. So moving away from airway clearance and moving on to exercise, give you time to read it. Physios have been certainly championing exercise for people with CF for at least kind of 25, 30 years. However, it seems to be consultants and medical physicians have really cottoned on to the fact that exercise is really important in about the last 5 years. So it's almost like they've suddenly listened to us. But we've been talking about exercise for years and years with patients. So whether that's doing really good exercise testing for patients or exercise programs and things that you guys can manage to achieve at home. So if we start with exercise testing, I know that everybody hates coming for their annual review, to us in particular anyway, maybe it's just us, I don't think we're that different though, and having to do their annual exercise test. Now, we don't do a gold standard maximal exercise test because we don't have the facility, so we do a field exercise test, so something like a shuttle walking test or a 6-minute walk distance, and in paediatrics we do a step test. But they're really useful in evaluating year-on-year changes, certainly helping to prescribe exercise programs for patients and understanding that individual's physiological response to exercise as well. So whether they desaturate their oxygen levels or what their heart rate response is like, gives us an idea of their physical fitness as well. So like I say, the gold standard will be a full maximal cardiopulmonary exercise testing, but that's normally done in a laboratory. It's done hugely across America, but I think the rest of the world struggles with trying to have the facilities available for the number of patients that we need to get through these tests. So lots of physios will carry out field exercise tests, and it will vary on what you do as to what space you've got in a corridor or something. A shuttle walk test needs at least 10 metres of space. A 6-minute walk needs at least 20 metres of straight space, or a step, which obviously needs a very small amount of space. But looking at subjective symptoms as well, so that we can evaluate when someone's exercising, not just what's happening to their oxygen saturations and their heart rate, but also what their symptoms of breathlessness are as well. So we focus quite a lot on exercise. We now have an assistant practitioner who has an exercise physiology qualification, and she really drives our patients to do a lot of exercise. 2 years ago, we evaluated the kind of work and exercise programs that our patients were doing, and actually showed that, to our surprise, unfortunately, we weren't actually having a training effect in the majority of our patients. So that was slightly worrying, knowing that we were trying to do exercise with our patients every day, but actually we weren't achieving anything. So since we've had our assistant practitioner, we have much more structured exercise programs, and it's a much better assessment system and progression. And we've certainly just in the last month or so evaluated a cohort of about 20 patients and shown that we do have an exercise training effect. So at least what our patients are doing is actually now worthwhile and beneficial to them as well. So it's important to have regular exercise programs, just like everybody should exercise. And I'm not going to ask everyone how much they do it. I have been to the gym 3 times since I got here, so that's good. But, it's finding something that the person likes to do, that they're able to do. So weight-bearing exercise is important, obviously, for bone mineral density. So if somebody just swims all the time, that's actually not good enough because you're not getting any stress through your bones and joints, really. So we always look to do comprehensive, individual, tailored exercise programs that include strengthening, aerobic and non-aerobic work as well, and flexibility work as well, obviously, for posture and things. So there's masses of evidence on exercise. Few kind of high-quality, long-term randomised controlled trials, but exercise is perfectly accepted now that it is a mainstay of treatment. And we would say for our treatments with our patients that is as important, really, as doing effective airway clearance with people. So we don't really take any excuses that they don't want to go to the gym individually or they don't want to do things in their room. Things like the Wii and things like that make it much more accessible for people to do now, even in a small space or if they are confined to their room for things. So within about the last 10 years or so in physiotherapy, there's been a much more heightened awareness of musculoskeletal and posture. Certainly a lot of the work by a physio in the States called Mary Massery, who's really promoted the awareness of people being able to assess and getting early to treat musculoskeletal and posture issues. And when you first go into CF, certainly when I did kind of 16, 17 years ago, like I say, I used to call myself a respiratory physio. So you used to think all of that musculoskeletal work that outpatients or sports physios do, you can completely forget your ligaments of the ankle, your spine, whatever. You don't need it. But in CF, you completely need to remember everything about the whole body, which is why I say, you need to be a CF specialist physio rather than just a respiratory physio, because musculoskeletal issues are important throughout through everybody's lifespan, really. And they can change and have different impacts as your disease changes as well. So particularly posture, and I expect you all to sit up really good and straight when I talk about this, being aware of what is good posture and what is bad posture, really getting in there to treat symptoms early, because the longer you leave things, the more chronic they become, the more difficult it is to break the cycle of it and actually improve them. So certainly for musculoskeletal and posture, prevention is key, but I totally appreciate that that is then added in more things to do, more burden of treatment, and it's finding the time in your day to try and live your, independent life and stuff. So physios, I think, need to be acutely aware of giving too much treatment to people and make it achievable, a nice achievable programme. For us, we work, the Brompton is just a heart and lung specialist hospital. So we don't have any general areas of the hospital. So if we have somebody with quite complex thoracic pain or spinal issues, and it's beyond our realm of expertise, we don't have a direct specialist that we can refer on to. But obviously, most people in the CF centre would work in a more general hospital, and it's a bit easier to refer on. So it's a little bit more tricky for us to refer on, but that's the best thing to do, really. So the risk factors around musculoskeletal issues for people with CF are really complex. So it does kind of take on the whole body, really. So whether you're having steroid treatments as part of managing inflammation or infections, whether you've got chronic infections that then have an impact on your chest biomechanics, things like that, just from your vitamin levels, your body mass index, and your lung function can all impact on your chest wall cavity and your general musculoskeletal system. So thinking about what our patients have said to us, we've been looking at posture over the last kind of 18 months or so. And like I say, we totally appreciate the burden of treatment, but also doing little things like giving a laptop riser to somebody who normally sits with a laptop on their bed, so not the best posture because you're really hunched and flexed over. Breaking that habit, reducing their pain down, things like people saying that they don't like their hump back, they can't wear strappy tops, they feel very conscious of what their posture is like because they might look slightly different to their peers. So doing a lot of kind of core stability work with people, postural work, flexibility work with people. And this kind of, the whole musculoskeletal aspect really fits into a complete vicious circle around CF. So how things like repeated coughing and increased infections and sputum can impact on poor posture, coupled with things like osteoporosis and low bone mineral density, reduced activity because you don't feel so well, you're more breathless, potentially have an impact on urinary incontinence as well. So maintaining good posture when you do your airway clearance techniques and doing things like the NAC and things like that. So this is quite a busy slide, and I meant to bring some Coke cans with me, because you can think of the thoracic cavity as like a sealed can of Coke or whatever, because you've got obviously your vocal cords at the top, and you've got a sphincter, say, in your pelvic floor. If you have a weakness, either area, then you've opened up your thoracic cavity to have a weakness in it. So certainly if you have any aspect of urinary incontinence in your pelvic floor, you've got obviously a weakness lower down. From things like repeated coughing, forced expiratory manoeuvres, it's a great pressure within the thoracic cavity. And it's a repeated pressure as well. So it's constant thinking of how your airway clearance interacts with your musculoskeletal and your posture issues, really. So you need to try and just be aware of that and manage it as much as you can and break that cycle, really. So when should we look to address or treat posture? Well, like I say, I work in adults. I have worked in peds previously, but by the time people come to us, and if they've got postural abnormalities, and everybody in every walk of life can have a postural abnormality, it's then quite difficult because it's a chronic problem to try and get in and break it. So the best time to try and get in and break it is around kind of 11 to 12 years old, really. So lots of our paediatric colleagues are really focusing on annual posture assessment, giving annual postural exercises as part of everyone's normal regime. By adulthood, we would expect them to already be doing things like that. But like I say, it's only really been an awareness of it around for about the last 5 to 10 years or so. So it's minimising the difficulties that people have and trying to improve things like pain and function for them. So just a few pictures of exercises that are really quite simple to do. So you don't really need a huge amount of specialist equipment. And these are really good for anyone to do. To be honest, for the last month, sitting at my computer writing talks for here, I kind of gave myself a bit of thoracic spine ache, a bit of shoulder ache from it, and got stiff from it. So things like extending over the back of a chair, doing humping and hollowing, certainly some rotation, getting your it's thoracic spine really that kind of gets really stiff in people with CF. So using things like foam rollers to just extend over, or putting a towel between your shoulder blades, things like that. And just being creative, really. So briefly onto urinary incontinence, we know from evidence over the last kind of 10, 15 years or so that the prevalence is increased in people with CF compared to people without CF. But the influencing factors are certainly a lower FEV1 and poorer nutrition for people. And like I say, you've got that repeated constant pressure of coughing, or we ask you to do forced expiratory manoeuvres through lung function from doing huffing, things like that. And it's all increasing your intrathoracic pressure, putting pressure on your pelvic floor. So Sue and I looked at the quality of life of our patients, and certainly the three activities that were the most significant with impacting on people's continence ability were coughing, laughing, and sneezing. And obviously laughing and sneezing are not physiotherapy treatments or aspects, but they're aspects of normal life that actually, if you do them, you've got to still try and maintain control of your pelvic floor. So again, like I mentioned earlier, prevention and management is really trying to get everyone to do pelvic floor exercises every day, and I expect a lot of you will be doing them now as I talk about them. This is what happened in the physio course yesterday. We were talking about incontinence, and you couldn't see people doing them, obviously, apart from their eyebrows raising, which is normally the biggest giveaway. But doing things like the knack, so pulling up and in to contract your pelvic floor, holding it, and then pulling up again to trying to get your slow and fast muscle fibres within your pelvic floor. You know, people say do them when you're washing up, do them at the bus stop, things like that. I think certainly when we looked at our patients, the vast majority didn't do their pelvic floor exercises. And I think people start them only when they've got a problem, which is a little bit too late, but you know, something is also better than nothing. But things like when you're doing airway clearance or coughing or huffing, lung function, you need to really remember to try and do the knack. And it's not just women that are affected, males as well. Males complain of more fecal incontinence rather than urinary incontinence. It is very small numbers, but maybe that's because it hasn't been asked enough, it hasn't been reported enough or assessed. So another aspect of the complex regime of physiotherapy for CF is inhalation therapy. And this is quite a fast-moving business, really. So whereas airway clearance has been slow to kind of develop new exciting techniques, and you'll probably say there aren't any exciting techniques, inhalation therapy really moves on quite a lot. So like I say, when I started in CF kind of 16, 17 years ago, it was really noisy, clunky air compressors that were really slow to deliver a medication. We had kind of a couple of antibiotics that we would nebulise. And yes, there was DNAs around, but again, that would take a good 15 minutes to nebulise, things like that. Inhalation therapy devices these days have moved on to be much quicker, much more efficient, and give people a greater deposition. And to be a lot more smaller and portable, and a lot of the new ones are silent. Now, I appreciate on here, I know that in Australia and New Zealand you have things like the eFlow, the picture in the middle, I don't think the pointer's working. Oh yeah, it is now. That's the iNeb. So we've had the iNeb in the UK for about 7 or 8 years now, and it's a mesh device, same as the eFlow is, but the difference with the eFlow is that runs continuously. It's a silent device and it's very efficient, but it runs continuously. So if something runs continuously, when you breathe out, you're not getting any drug going in, so you're wasting it. With this device, you put less drug in because it only works when you breathe in, so it's really efficient. Unfortunately, it is linked to one drug. We can use it with other drugs, but you have to be on a certain form of colistin. You have to be on promixin for it. Certainly with the advent of dry powders, so obviously this is for bronchitol, for inhaled mannitol, so a very small dry powder inhaler, which people with CF, really the only inhalers that they're used to taking are things like Ventolin. So to have things that enhance or assist airway clearance in a little dry powder, obviously DNAs is a liquid and has its place totally. I'm a great fan of DNAs. You know, hypertonic saline has its place, it's very good, but people complain about the taste of it, and it's another nebulizer that takes 10-15 minutes or so. This being 10 capsules, you know, we've only been using it for about the last 4 or 5 months or so, but our patients, we thought they wouldn't like 10 capsules because 10 is still quite a lot of things to do. This lady here, Anne, she takes it at breakfast. She likes the taste of it because it's sweet, things like that. You've got Toby Podhaler coming, and obviously there's the Novartis stand here, which for dry powder inhaled antibiotics, rather than having to dilute something or sit on a nebulizer for kind of 10-15 minutes, is a great step forward, really. So I haven't got a picture of Toby Pod here. This is dry powder colamycin. This is Colabreathe down in the corner, which we've just had launched in the UK. But obviously Toby Podhaler being 4 capsules compared to 5 mils of Toby to be used, obviously made by the same company and the same efficacy. I think certainly in our patients we've got a good 70 or 80 patients on it, and really well tolerated. Because it's a dry powder, it's so much more portable and accessible for them. And we hope that it will improve their adherence. We're looking at an adherence study and things at the moment. Because we know that things like cleaning is a really bad aspect of having to take any nebulizers. And we go on and on and on about cleaning to our patients. And so we studied the cleaning of what people do. So just 30 of our adults using a conventional system, so a Pari-LC+, using an eFlow or using an iNeb. It was really tricky for us to find any patients that used the Pari-LC+. It took a good 6 months to get those 10 patients because the majority of our patients now use an eFlow or an iNeb. But looking at the cleaning, and so we evaluated this in their home environment, so it was as true to life as what we could get. And looking at a single dose of DNAs, because every patient that we had was then on the same medication. Obviously, you have different fill volumes of different drugs and things. And looking at the time that they took to take it, put their things together, and then what their cleaning was. And lo and behold, cleaning was pretty much non-existent. And I don't think this is just a Brompton patient thing. I'm sure that, you know, everyone doesn't conform to the absolute manufacturer's recommended guidelines. We didn't have anyone who kind of scored 10 out of 10 on their cleaning guidelines. there was often too short a rinsing, or not the right liquids were being used, no detergent was being used, things like that. And we had a huge variation in the inhalation time, so the performance of the device, which was probably due to, because all of the systems that we used were 4 weeks old with patients, so nobody had an absolute brand new, or nobody had it for 6 months or anything. So it does influence performance, and potentially, you know, the amount of drug that you're getting as well, not just thinking about what bugs that might be harbouring in the equipment as well. So we totally appreciate that a typical day is really complex, and we're all saying live your life as much as you can, really good quality of life, be independent, but then physio in particular shoves masses of treatment at you. So it's working together with your individual physio to try and get the best regime for you, really. Thinking about, you know, what affects the dose and deposition, well, yes, the efficiency of your device certainly affects it. But with things like the newer devices, and certainly the eFlow and iNeb, and then dry powders, should be more efficient than your traditional jet nebulizers, really. So thinking about the breathing pattern that somebody is doing, certainly getting the right inhalation technique for a dry powder is really important, and not taking it too quickly. Getting the right breathing pattern on a wet nebulizer is important as well, so that you get good distribution of drug within the airways. Because if you're bothering to take it, you want it to get to the parts that you want it to reach. So thinking about everyone's individual inhalation strategy is, there are some core principles, but again, you need to work through this with your physio as to what is best for you. So bronchodilators would always be taken before hypertonic saline, before airway clearance. Your inhaled antibiotics should always be after airway clearance. There's no point putting an expensive drug onto masses of sputum that you're then going to expectorate out, because you've treated your sputum that's in your pot rather than treated your airways and the bacteria that are in there. Certainly with hypertonic saline and mannitol, we do it before or during airway clearance. And then DNAs, pulmozyme is one of those ones that is really individual. So whether you take it an hour before you do airway clearance, the minimum would be half an hour. You can't take it directly before, or whether you take it directly after airway clearance, so it works on the stuff that you couldn't actually clear. And antifungals, again, we would always do post airway clearance, but obviously not everybody is on them. Thinking about the upper airway and not forgetting it, it's not just your trachea down that you need to pay attention to. And you need to really think about your nose and your oropharynx area being as one single united airway. Sounds like an airline. So always think about United Airways. If you're going to go to America, you'll really think about it. So we know that at least 80% of people have sinus issues, but they also don't really report them as being a problem. So is it that you just accept those symptoms of having a really stuffy nose or a runny nose and not being able to breathe through your nose very well, because in airway clearance we're always asking you to breathe through your nose, things like that. But knowing that the epithelium in the mucosa that you've got in your upper airway goes down into your lungs, so infection can kind of coexist and cohabitate the lung and the upper airway. Treatment options, surgery is a last resort, but some people with very severe sinus problems do need sinus surgery. Looking at down here, so this is sinus irrigation. Something called nasal washouts, or the Yarlanetti, doing it with a jug. So you actually tip your head on the side and have mucus draining out. Certainly the use of therapeutic ultrasound for sinusitis and sinus pain is being evaluated by a physio in the UK, and also jointly with Mark Elkins over in Australia. Thinking about maybe using your inhaled antibiotics via a mask. We focus so much on using them through a mouthpiece for a nebulizer, and certainly with dry powders through a mouthpiece, you've still got bacteria within your sinus cavities. So certainly exhaling a dry powder through your nose, that might potentially help. Or if you're on a nebulizer then, and you've got bad sinus disease, maybe doing a nebulizer via your mask a couple of times a week. Certainly in post-transplant patients, we would advocate doing inhaled antibiotics, nebulized ones, via a mask to target the upper airway. Physios are really important when people with CF are pregnant just because there are normal complications with pregnancy, but then CF can add and increase those complications really. So we know that the predictors of a poorer outcome maternally, if your lung function is around FEV1 of 50 to 60%. We've recently done a review of our 48 pregnancies over the last 13 years, and we've had a huge amount of successful pregnancies, but it's just looking at the predictors of what might make you have concern. So around 50 to 60% of FEV1. Adherence is massively important during pregnancy, and obviously even more important afterwards, appreciating that people have different priorities afterwards as well. Certainly with our patients who are pregnant, we would look to see them every month, so whether that's at clinic or on home care. Just knowing that estrogen in itself increases mucus production in anyone who's pregnant. So if you add in CF as well, you're going to have an even greater sputum load potentially. Knowing that progesterone normally would increase somebody's respiratory rate, so hence somebody with CF may have a greater effect of that and greater shortness of breath and even a greater higher nutritional demand. So thinking about what we would do, like I say, physio is important throughout each trimester really, but pre-pregnancy, trying to optimise education and awareness and kind of preparing somebody. We obviously don't always get to see somebody who is planning a pregnancy. Sometimes it's a little bit of a surprise or a shock. But certainly around the second to third trimester, from a physiotherapy aspect, we would look to, because the bump is growing, the diaphragm is pushed up, it's much more difficult to get air into the bases of your lungs, using something like positive pressure to open up those bases, just to try and give the mother as much comfort and chance as possible as not having too many infections through pregnancy. And then post-delivery, making sure that you get that kind of good regime for the mum while caring for their newborn as well. And this isn't one of our patients. This is my team lead physio who, the day before she went off on maternity leave, and we just thought we'd get some photos of her. But making sure that you are supportive and you do airway clearance in good supportive positions, because in late stages of pregnancy, people are going to be uncomfortable anyway. So, but still concentrating on exercise and kind of core stability work for them as well. Post-pregnancy, like I say, making sure that you can get a good regime going, regular review. People will often do no treatment at all for a good couple of weeks, but it's that time post-pregnancy that you may have a greater dip than in your late stages of pregnancy. So it really is kind of good assessment and getting in there, trying to get people to do as much as they can. We have a big role in palliative care through symptom management. So obviously with symptoms of breathlessness, anxiety, physios are really good at trying to alleviate those. But many CF teams these days work with a specialist palliative care team as well. So that partnership between your normal multidisciplinary CF team and your palliative care team. So things like maintaining patients' dignity, if they still want to be able to walk to the toilet, assisting them with how they can do that, with their kind of good support of whether it's with non-invasive ventilation to reduce the work of breathing, or oxygen, or just breathing pattern management for them, and making sure that you don't overburden them with too many medications that are just making things too much of a struggle. So thinking about the extended skills, and obviously that's I had to say that was a Helen, because there she is in her physio uniform, not pregnant. But thinking about the extended skills, certainly in the UK, we can have physios who are independent prescribers now, and Helen is one of those. We run a home care service. We've had it for about the last 8 or 9 years. So a couple of days a week, we will go out and visit patients, and not to provide physiotherapy, as in assisted airway clearance. It's much more of an assessment, any problems, what do we need to change, rather than giving regular routine treatment. With 600 adults, we could never go out and do that on a team of 5 or 6 physios. Certainly within critical care, and the advances in things like, managing patients within the critical care environment and being involved in weaning, things like that, physios have a big role. We run our NIV service for our CF patients because we use it so much with airway clearance and exercise in our patients, and not just in respiratory failure, although any other patient who's non-CF gets looked after by the respiratory support service. But we integrate it much more into the kind of daily treatment regime for people, and then really regular assessment and kind of picking up problems sooner rather than later. So in summary, physio for CF fortunately is very diverse. It's not just airway clearance, because I think if it was airway clearance and you just focused on the lungs, you would be doing a complete disservice to your patients who obviously have whole body problems that need attention and assessment and addressing. Yes, it's a mainstay of daily treatment, but yes, we know how unpopular we are. But I think to be a really good physio, a really good CF specialist physio, you need a really comprehensive treatment toolkit. If you have inadequacies in your kind of treatment skills and expertise as a physio, you're doing your patients a disservice by not knowing as much as you can. We obviously have to individually tailor treatment programs. No two patients are ever the same, and obviously frequently you'll reassess because you can be different day to day, week to week as well. And adapting physiotherapy appropriately at different age points. So for infants, for children at transition, and then growing adult population, and then certainly we have elderly patients, getting used to things like talking about osteoarthritis with patients and management of things like that, along with their normal CF care. But being completely aware of the treatment burden, because it's very easy to add in treatment, say, oh, well, you need to take this nebulizer, you need to do that lot of exercise, but actually there's only so many hours in the day, and you really don't want to spend every minute of it doing physiotherapy. So knowing that adherence is key, but also making it realistic. I think that's it. Thank you.
Thanks very much for that. That was awesome. Hey, just a question. I've come from a music background with singing and band stuff, and learned how to do diaphragmatic breathing. And you sort of take for granted that most people don't actually know how to breathe properly, you know.
Yeah.
And I sat down with my kids the other day, one's with CF and one with hasn't, and they're sitting there going, like this sort of stuff. And I sort of said, no, stand here, feel this. And what's, in your opinion, is it good to teach them how to do diaphragmatic breathing?
So, as you say, diaphragmatic breathing, people normally assume that everyone does it, but actually, if we looked at everybody in here, probably some of you wouldn't be. So we always say to try and relax the upper chest and breathe from the lower chest. We don't even really call it the diaphragm because a lot of people don't know where the diaphragm is. So rather than putting your hand on the upper chest, which can stimulate upper breathing patterns,
put it here.
Hand on the lower chest and relaxed. Now, some people, if they've got a high work of breathing, they won't be able to relax the upper chest. So you need to try and passively fix. So using positioning, maybe forward lean sitting, if they do have a high work of breathing, just to take that whole effort away. In my talk tomorrow, I've got an old patient who you can really see her work of breathing. She refuses to wear oxygen, things like that. But really trying to get a relaxed, lower breathing pattern. And it does take time. It's not kind of taught in 10 seconds.
I do it every day with them.
It's repeated things.
Yeah.
It's training your brain to breathe in a different way because you've got a habitual pattern of breathing with a lot of effort as well. So breathing is really inefficient. It's hard work. So doing it in a good way is better.
Oh, that's good. Okay.
But things like singing and stuff is really good. We have a singing for breathing tutor at our hospital with whether it's for COPD, and they do individual lessons with CF. So singing is also really good at regulating your breathing as well and being aware of how your chest moves.
Well, that's what we're doing. Actually, we have a family band, so I thought, well, you just take it for granted because, as I say, it's sort of something I've done for years, and I can't breathe the other way.
Breathing's natural, but breathing can be so wrong.
Oh, thanks for that.
Thanks very much for the talk. It's sort of a comment and a question. We've found with our daughter who's 13, and I appreciate this might not be the most appropriate physio technique for everybody, but the one thing that consistently gets her coughing up sputum when we do all the physio and neb and so on is tickling. And I just wanted to get your feedback. Is that actually an effective technique that people are using? Because it seems to work for us fantastically.
Yeah. Okay, so tickling is not a textbook technique, but if you think about what happens with tickling, you do change your airflow because you take deeper breaths with it, and you change your ventilation. So from those two principles, tickling and laughing Now, I wouldn't say that it should be the only thing that you do, but certainly in children, tickling, because it naturally increases ventilation airflow, yeah, it's a good thing, definitely. Combine it with other things, but you're never going to find it in a physio textbook or guideline. But think about what it does. If you tickle, she's laughing and gasping and stuff like that. That's taking deep breaths, changing ventilation.
Maybe someone should do a study on it.
Yeah, there you go. You can do it.
God, I hate being tickled. Oh.
Yeah, I'm not going to go around tickling.
Please don't tickle me. Penny, that was absolutely fantastic. Like you said, it's physio is one of those things that everybody's like, physio, but it's just so important. So many other things flow from it. That was a fabulous talk. Penny will be getting a gift from us later, so please don't worry about that. But she's got a lot of other work to do as well in the conference, so thank you very much. We're now at morning tea, and we'll see you back in half an hour.